All right, so we're going to begin our discussion on diseases of the circulatory system. Just a quick refresher, the circulatory system revolves around the ability of the heart to pump blood in order to supply oxygen and nutrients to the rest of the body. It does this with help from the respiratory system, as the respiratory system is the primary way in which we bring oxygen in into the body and expel carbon dioxide, which is one of the waste products that will be contained in blood. As a reminder, in general, you have two circulatory sides of the heart. You have your right-sided or pulmonary circulation and your left-sided or systemic circulation. Make sure you take a refresher of the anatomy of the heart. So, cardiovascular diseases, there's a couple different types, but generally you have issues with the conducting system of the heart, issues with rhythms of the heart, either being too slow, too fast, or issues with the function of the muscle of the heart. Currently, cardiovascular disease as a category is about 1/3 of all deaths in the developed Western world. So, cardiovascular disease has some very stereotypical symptoms. You will notice some of these symptoms are incredibly similar to what you see in respiratory diseases. You get chest pain or angina, have dyspnea, trouble breathing, tachypnea, rapid breathing. Those two things go hand in hand as the body is unable to provide oxygen to its tissues, and it's going to increase breathing rate because of that. You have palpitations or heart flutters, cyanosis, which is turning of the fingers, toes, and skin turning blue. Edema is swelling, fatigue, and syncope. So first thing we will talk about is coronary artery disease. This involves the arteries supplying the myocardium. So as the aorta comes out of the heart, it immediately splits into a right and left coronary artery. The heart supplies itself with blood, obviously. So of course, the first blood vessels that come off supply the heart. The heart contains a large amount of muscle and therefore needs a lot of oxygen availability. Okay, the heart primarily functions on aerobic respiration. So you need oxygen for that electron transport chain. CAD is normally associated with severe chest pain that's typically sudden onset and is also associated with a condition called angina pectoris, which we'll talk about as its own separate thing upcoming. Angina pectoris doesn't necessarily mean that you have coronary artery disease, because you can have angina without actually having a problem. There's stuff called like Prince-Metal angina, which is just inappropriate vasospasm, and that can happen in anybody. There's different subclassifications. In general, though, your arteries become narrowed. There's typically atherosclerotic deposits, which we'll talk about shortly, and you get ischemia. And if it is worse, you have a myocardial infarct or a heart attack. So causes, again, fat-containing plaques. We'll talk about the pathogenesis of this later on, but you get a narrowing of the artery and therefore less blood and less oxygen supplying the myocardium. Arteriosclerosis also happens in those that are diabetic and elderly, and arteriosclerosis is hardening of the arteries, whereas atherosclerosis is plaque formation in the arteries. Over time, CAD may be occurring in somebody and they don't have symptoms, but over time it leads to the myocardium becoming weak and eventually dying, and that is an MI, a myocardial infarct. Risk factors. This is stuff that everyone's going to know. This is one of those conditions that does affect men more than women, older than 40 years of age, genetic predisposition to this disease, and interestingly, something that's been given a lot more notice in recent years is postmenopausal women also are at higher elevated risks for coronary artery disease, likely related to the effect of estrogen on the body. Estrogen is thought to have a somewhat protective mechanism for women from some of these cardiovascular diseases. But once a female goes through menopause, their hormone signaling has changed significantly, and they do seem to actually become higher risk for these problems. Individuals that are Caucasian or white, history of smoking, residence in an urban society, so environment, big risk factor, and hypertension. Symptoms, angina pectoris, big one. If it's sudden and severe, it might be myocardial infarct. You might have burning, squeezing, a crushing sensation that doesn't go away, and pain radiating into the left arm, neck, and left side of the jaw. Nausea, vomiting, weakness are also incredibly important. With CAD, though, you may or may not have changes in the electrocardiogram, but it's important to have an electrocardiogram for high-risk patients. Treatment. So, goal here, if the pathophysiology is inadequate oxygen and blood supply, what do? You restore adequate blood flow. So you'll use vasodilators, and you can also do something called angioplasty. With angioplasty, see this here. This is using a catheter. So what they will actually do is feed a catheter up, typically up through the femoral artery. They feed it all the way up through the abdominal aorta, and then eventually into the location of the narrowing, and they expand a balloon to restore the lumen of the artery. You can also see bypasses being performed. So in this case, you're typically taking a piece of the saphenous vein from the leg, and they transplant it to the heart. They attach it directly to the aorta and bypass the site of the occlusion, allowing blood to flow around it. Angina pectoris. So this is that chest pain due to ischemia during or shortly after exertion. This is often one of the first symptoms. A key thing that separates angina pectoris from a myocardial infarct is that it is typically associated with exertion. If somebody has stopped exercise, walking, etc., the chest pain should improve. So symptoms, again, it's left-sided chest pain. Pain can radiate into the arm, specifically between the shoulder blades. Left arm, typically in that ulnar nerve distribution down the side of the pinky, and even the left side of the jaw. Person might also get a major increase in blood pressure. This is just showing you the radiating pattern of angina. So diagnosis of this, typically previous exertional chest pain episodes. An ECG may show signs of ischemia, but it should be a relatively normal ECG. It's important to note that a normal ECG does not exclude a diagnosis of angina either, though. Diagnostic measures other diagnostic measures will also be performed. They might do things like chest x-ray, chest CT, etc., and even things like echocardiogram. Typically, treatment, though, is the administration of nitroglycerin tablets under the tongue, and normally 2 to 3 of those will prevent and restore normal oxygen flow. Myocardial infarct. This is ischemia that causes myocardial tissue death. This can happen at rest, it can happen from exercise, and it can happen just at random. It doesn't have to necessarily be, it could be an emboli that also causes it as well. In fact, a thrombosis is the most common cause of MI. Typically, if somebody has true ischemic chest pain and it's not resolved within 6 hours, there will be death of the heart tissue. So this is going to be sudden and severe. Sudden, severe, and sustained. That is the 3 key S words we think of when we think of heart. You're going to get a feeling of like something's just crushing your chest. It's something that you commonly hear a lot, and it's apparently something that only people that have had a heart attack can really describe it as. It's about the only way to accurately describe it. So symptoms, this is showing you a obstruction in the left anterior descending artery of the heart coming right off of our left coronary artery. right here, and then you move into your circumflex, going around the side. This is the most common site for a myocardial infarct, and it can be incredibly deadly. In fact, this is often termed a widow's maker. Diagnosis, all about history, ECG, a chest radiograph. You want to determine if there's fluid backup in the lung, the heart's enlarged, etc. And then laboratory tests. The big ones we look for are your creatine phosphokinase, your troponins, and your lactate dehydrogenase levels. AST, or aspartate aminotransferase, is also relatively important. Your CK and troponin levels are very important for your first couple hours up to a day after. And then your lactate dehydrogenase will actually be more of a long-term indicator that an MI did happen, and it will peak after about 48 hours. Each of these tests, specifically the troponin and lactate dehydrogenase, there are isozymes, meaning these are actually kind of families of enzymes, and you're going to be looking at very specific versions of them to differentiate out heart muscle from something like liver damage or skeletal muscle damage. Treatment: oxygen, morphine for pain, aspirin to help thin the blood. As we've talked about before, aspirin as an NSAID is a blood thinner. And then vasodilation via nitroglycerin intravenously. And then you might give some other drugs like amiodarone to help improve blood flow. Cardiac arrest is the sudden unexpected cessation of cardiac activity. This is not the same thing as a heart attack. Cardiac arrest means that basically the heart has actually functionally stopped working. The patient will become unresponsive, and there will be no respiratory effort or pulse at all. There's many different causes to this, and it's even possible that it can just randomly occur. In fact, there is a phenomenon called sudden cardiac death that can happen to anyone at any time. This is a life-threatening emergency, and it is typically treated with cardiopulmonary resuscitation and defibrillation via an AED. It's one of those things important for everyone to have CPR AED training via any of the big organizations, but the American Heart Association and the American Red Cross are definitely two of the most commonly accepted and better organizations to do the training. The treatment: you institute it quickly. Any more than about 4 to 6 minutes, and there will be brain death. Cardiac defibrillation and ambulance. It's important that people also realize CPR is a violent process. If you've never actually witnessed it performed in front of you or had to perform it, it's rather shocking the first time that you see it. It's relatively normal for people to have sounds of ribs breaking, as well as the cartilage on the anterior portion of the rib cage that will also fracture and break. It is a violent process. The chest does, the sternum does need to be depressed in order to actually make contact and have that squeezing motion on the heart. It's a very intensive process. It's very physically demanding, and generally the success rate for CPR on its own is rather poor. You add an AED, again, depending on the exact issue, an AED can improve the chances of survival, but an AED only functions with certain types of dysrhythmias, specifically ventricular fibrillation. That's why it's called a defibrillator. Any other type of dysrhythmia, it actually will not do a shock. Hypertensive heart disease. So this is a very common condition associated with atherosclerosis, arteriosclerosis, and kidney disease. It's the result of chronically elevated blood pressure throughout the entire body. Common symptoms for this are headaches, epistaxis, which is nose bleeding, lightheadedness, and syncope. The risk factors It's everything that we always talk about related to lifestyle, but you've also got things like age, hereditary, and diet in here too. Type A personalities, interestingly enough, this is a case where people with certain psychological, personalities essentially. While the idea of classifying types of personalities isn't exactly scientific, the type A personality is someone who's very assertive. They're a dominant person. They're always proactive about everything, right? They don't ever wait for the last possible second to get things done. So those are the people that are also more likely to suffer from this. Diagnosis, you're just measuring blood pressure. The standard level currently is 140 over 90 millimeters of mercury to have a diagnosis of essential hypertension, and you're looking for that level or higher on at least 3 subsequent presentations to the practitioner. Generally, though, anybody that is 120 to 140 is thought to be borderline hypertensive, and the absolute ideal blood pressure reading is between about 110, 120, and then 70 to 80 for your diastolic. Treatment, drug therapy, diuretics. So you use diuretics to increase urine output, which reduces circulating blood volume. You'll use ACE inhibitors, which we will talk about later, that produce vasodilation and also increase your renal blood flow. There's ARBs, which are angiotensin receptor blockers, and there's also ACE. Remember, ACE is your angiotensin converting enzyme. So these two guys kind of work on that renin-angiotensin-aldosterone system, so make sure you review that. And we also have calcium channel blockers that help slow heartbeat and reduce by reducing conduction in the heart. And a reduced heartbeat basically means the pump is pumping less blood, which gives less pressure. You'll also treat it with lifestyle modifications, so diet, exercise. If you're chronically stressed, removing stress can also be a major thing. Congestive heart failure. So this is when underlying conditions compromise the function of the heart to the point that the heart can no longer meet the demands of homeostasis. The heart is essentially dying, and there's no coming back from it. Causes, all of the things that are listed here, either individually or together, can all lead to this. The more of these you have, the worse your outcomes will be. So in this case, people are going to be experiencing a slow onset of increasing shortness of breath. They're going to have increased heart rate and respiratory rates, anxiety, distended jugular veins, lower extremity edema, and then their livers and spleens will be enlarged. Hepatosplenomegaly is the term for all of those guys combined. Diagnosis, history, physical exam, breath sounds will be diminished, so in your lungs. ECG often has some stereotypical findings, and then a cardiac catheterization can also show. So this is showing an X-ray of a person with congestive heart failure. You are seeing in these areas that I'm kind of, in fact, let me just draw it. What you're seeing here, what I've kind of outlined is fluid building up in the lungs. Fluid in the lungs will build up and kind of then expand out slowly. And now, if you also look, you got this incredibly large heart shadow. Heart shadow should not be that big. The heart's enlarged, so there also is some form of underlying cardiomyopathy in this situation. Treatment, again, just like before, you're going to treat this like everything. You're going to treat it like it's underlying conditions. So if you have high blood pressure, you use ACE inhibitors and ARBs to increase your blood flow, diuretics to reduce blood volume. You may use medications for dysrhythmias, etc. If it's acute congestive heart failure, it can respond well, can have a positive outcome, but not always. Chronic, true congestive heart failure, though, is always a bad outcome. So next, cor pulmonale. This is just an old term for right-sided heart failure. It results in enlargement of your right ventricle and is typically the result of a primary lung disease. So you're going to get distended neck veins, edema in your extremities, an enlarged liver, trouble breathing. Because again, the respiratory condition is the true cause. So patient's going to have hypoxia. They have the pulmonary disease, something like COPD, emphysema. And you'll do a lot of the same tests as you would for a regular heart failure to ensure you treat it with that. Pulmonary edema. So this is a condition where fluid shifts into the extravascular spaces of the lungs. Like we showed on the x-ray before, that fluid starts to build up. It's because there's nowhere for the fluid to go after the blood goes from the heart to the lung. If the heart is failing and the heart cannot pump blood out, the first place that it will back up, if there is left-sided heart failure, is in the lungs. So causes, again, left-sided heart failure. But you can also see all of the other things here that potentially impact our cardiovascular function in general can cause this. Pulmonary embolus also is another cause of edema, but any other condition that can cause retention of fluids can also lead to this. Typically, you place the patient in a Fowler position and use oxygen therapy, diuretics, vasodilators, morphine sulfate for venous dilation, and beta-2 adrenergic drugs for bronchial dilation. These are similar to, these are basically the drugs you use for people that are having like asthma attack. So cardiomyopathy. There's different types of cardiomyopathy, 3 main ways to classify it. You have dilated, hypertrophic, and restrictive. But cardiomyopathy is non-inflammatory disease of the actual muscle itself that results in enlargement and ventricular dysfunction. Dilated cardiomyopathy, often associated with chronic alcoholism, autoimmunity, and viral infections. Hypertrophic cardiomyopathy is typically genetic and is often deemed idiopathic, meaning we don't understand why it happens. And then restrictive cardiomyopathy is a rare condition that occurs when an infiltrative process of the heart causes fibrosis. So the heart wall actually thickens and stiffens. One thing to talk about with hypertrophic cardiomyopathy, this is a non-functional hypertrophy of the cardiac muscle. So if you recall back to anatomy and physiology, muscle is made up of tons of different proteins. You've got your actin and myosin, but you also have proteins like titin, troponin, tropomyosin, etc. They all are involved in making up your muscles. Well, you can also have a functional cardiac hypertrophy, and that's what you actually typically see in athletic individuals. Their heart can be bigger, but there's a key measure of heart muscle function called contractility. In the athletic population, they retain contractility. In the non-athletic population that has hypertrophic cardiomyopathy, they do not keep contractility of their myocardium. Basically meaning the muscle gets bigger and it can't contract to make up for it. Okay, because as muscle hypertrophies, it can change its physiology, but that's well beyond what we need to talk about here. But just keep that in mind, that it is possible to have an enlarged heart if you're very athletic and there's not actually a problem. So symptoms. Would you guess? It's the same exact symptoms that you see with almost every other cardiovascular disease. And if you look here, a lot of the same exact medications are going to be used for this as with other cardiovascular diseases. Big thing is that you're going to look for any underlying issues and address those as. So pericarditis. Pericarditis is acute and or chronic inflammation of the pericardium, which is the sac that kind of wraps around the heart. It's really caused by, commonly caused by infection, neoplasms in the mediastinum, etc. And it can also be the result of infection from somewhere else in the body, such as the case of rheumatic fever, which is a strep infection that actually ends up resulting in a sort of pseudo autoimmune process where the body is responding to an antigen of the strep bacteria that is almost identical to the myosin in the cardiac muscle, and that actually results in breakdown of myocardium, or the pericarditis. Sorry. So, you're seeing basically the primary pathophysiology here: fluid compressing the heart wall, heart can't expand, get fluid back up into the lungs, decreased output. A lot of the same symptoms here, except if we think about the true underlying cause being an infection, you're going to see things like your fever, your fatigue, and your chills, stuff that is incredibly related to infection. Treatment, people will undergo like a cardiopulmonary rehab setting. They can also do surgical drainage, aspiration, rest, pain medications, and you'll also see drugs for the infection, etc. Laboratory findings, you're going to look at white blood cell count, erythrocyte sedimentation rate, and your cardiac enzyme levels to ensure that you're ruling out other conditions as well. Now, myocarditis is inflammation of the heart wall itself, the actual myocardium. So this is also associated with infections, like your rheumatic fever, but there's also certain toxins like lithium. People that are bipolar are often given lithium, which is why blood lithium levels need to consistently be monitored. You can also see alcoholics, radiation, and other types of chemical exposures can cause this as well. Treatment. So again, you're going to treat it based on the underlying cause. Endocarditis. This is inflammation of the lining and valves of the heart. This is almost always infection, okay? But it could also be an autoimmune disease. You typically will see vegetative growths on the valves of the heart, like you see in this picture here. That was bacterial endocarditis. So Staph aureus and group A beta hemolytic streptococci and E. coli are kind of the big three to cause this. You can also be unfortunate and have what's called a septic emboli, basically meaning an embolus is carried away elsewhere, gets embedded in an organ, and results in new bacterial infection sites in other organs like the liver, kidneys, etc. Endocarditis, typically associated with urinary tract infections, dental abscesses, respiratory tract infections, and skin. Diagnosis, it's a CBC, blood culture, echocardiogram, and ECG. Ultimately, after that, though, you're treating it based entirely upon the underlying organism that's causing it. So we kind of already talked about this briefly, but rheumatic fever is a leftover response to a strep infection, specifically your group A beta hemolytic strep, that causes the body to attack the heart tissue because the strep has an antigen that mimics the cardiac myosin protein. Symptoms, again, all of our standard cardiovascular symptoms here. The key thing about this, though, is that this onsets weeks after the initial infection. So history, key part of this, knowing that they had an infection within the last, I would say within the last 2 months is a big thing here. Penicillins are typically very effective at eradicating streptococcal infections. And the person may be given even more antibiotics than may be necessary. One special test that you will see used here, though, is your anti-streptolysin O titer, which is a measure in the blood for the antigen of the antibodies for your streptococcal vaccines. So this is what rheumatic heart disease looks like when it's affecting a valve. You can kind of see the valve can't close properly. It's inflamed. It's nasty. It's all messed up. And in fact, the valve here is literally deformed, and this is its closed shape. Notice how there's a hole straight through. That should not be there. The treatment, they may do surgery, and sometimes people do need to replace their valve. Dental hygiene is directly related to this, and prophylactic antibiotics may be given. So, speaking of hearts, valvular heart disease. They're commonly congenital, but not always. It could be acquired via an infection or anything like that. It can also result from long-term stenosis, essentially, which is like a hardening of the cusps. So talking about your mitral valve, you get hardening of the valve, and that prevents complete action of the valve. That's going to reduce the amount of blood flow. So again, reduced blood flow. What symptoms do we get? Fatigue, cough, trouble breathing, especially if it's left-sided, like the mitral valve is, because that sits between the left atria, left ventricle. Treatment, you're going to limit sodium intake, use of diuretics, and surgical intervention to help fix the stenosis is often useful. And some individuals do end up getting valve replacements. It's rather interesting because they do use valves from pig hearts for this. Mitral insufficiency. Mitral valve won't close properly and allows blood to backflow. It's rather straightforward, and it's typically associated with leftover scar tissue from things like inflammation from an infection, myocardial infarct, or even coronary artery disease. Diagnosis, big one for this is echocardiogram. You're using an ultrasound to essentially see the murmur and the backflow of the blood. Treatment is bed rest, oxygen therapy, treat the underlying cause if possible, and then a surgical repair or replacement of the valve. If it's not treated quick enough, you can have congestive heart failure as a result. Mitral valve prolapse is when the papillary muscles, let's go back. One or more of the cusps actually protrudes up into the left atrium. Normally, the cusps actually kind of hang down into the ventricle, and that's because they open into the ventricle. If you have papillary muscles that are malfunctioning, they can also lead to this or make this condition worse. This is basically your insufficiency just turned up to 11 and much worse. So your symptoms, again, are standard cardiorespiratory symptoms. One thing to note with this is one of those heart conditions that for some people does actually feel like it's anxiety. Diagnosis, so you can actually hear a clicking on auscultation if you're using the bell of a stethoscope. Echocardiogram, though, is the confirmatory way to find this. One other thing that is associated with this is premature ventricular contractions, or PVCs. PVCs on their own are not considered harmful, and they're not necessarily a diagnostic criteria for anything. They occur on their own. Many people have them, and some people have them on and off. So arrhythmias. This is deviation from the normal heartbeat, which is termed the sinus rhythm. These are irregular heartbeats, essentially, right? One of the four most common places where disturbances occur are your sinoatrial node or the heart's intrinsic pacemaker. AV node, which is kind of the point where the heart synchronizes timing of electrical conduction between the atria and the ventricles. Your bundle branches, which split your right and left to supply your right and left ventricles, and then your Purkinje fibers, which actually disperse out from your bundle branches and into the myocardium. So our outline of that is here. The symptoms, you're going to have palpitations. You can have tachycardia, bradycardia, the feeling of skipped heartbeats, syncope, fatigue, etc. Typically described as feeling like your heart misses a beat. Diagnosis, you use your 12-lead ECG, right? You've got, you're looking at your electrocardiogram. Echocardiography can help rule out other things. And then a Holter monitor is actually what's commonly used if this is found in clinic. You put the person on a Holter monitor for, at least 24 hours. Nowadays, they seem to do either very short-term, 1 to 3 day long, or they do very long-term, 30-day long ECGs. Treatment. So they can be drug-induced arrhythmia. So if it's drug-induced, you cease the administration of the drug. But you're going to use anticoagulants because arrhythmias can increase the risk of stroke. Within the right and left atria, you have a little pouch. And this pouch does not get a lot of blood flow. The blood flow is rather stagnant, and so it predisposes that area to clotting. So it is not uncommon for clots to form in this area. Well, the moment the atria are affected by an arrhythmia, the clot gets thrown. That leads to pulmonary emboli, and it leads to strokes. Pacemakers and implantable cardioverter defibrillators. These are used for people who have arrhythmias. Basically, what they do is they ensure that the heart maintains a steady pace in the case of pacemakers, and cardioverters basically are present to provide a sort of rescue type shock to restore proper sinus rhythms. Cardiac ablation. So in the case of something like an ectopic foci of electrical conduction, like a Wolff-Parkinson-White syndrome. So with Wolff-Parkinson-White, you're going to have like almost like a second SA node or a second AV node, something like that, that's generating electrical impulses that is causing a problem. So what you do with that, you do cardiac ablation. You kill that source of extra signaling. Shock, another important thing to mention, this is collapse of the cardiovascular system. You get inefficient cardiac output and reduced blood flow, inefficient and reduced blood flow to the entire body. It is life-threatening and does need emergency medical care, and it can be the result of nearly anything. Causes, again, a lot of times big important issues here. Typically damage to vital organs, and ultimately in the end, cardiogenic shock results in collapse of tissues such as the heart, brain, and kidneys, as they won't get enough oxygen and they will die. One of the most common causes that we think of is rapid blood loss or any other type of vascular compromise, but you can also see it with things like allergic reactions. The symptoms we always talk about, a person gets pale, they get clammy, rapid breathing, they get weak, thready pulses, altered level of consciousness, they might be incredibly thirsty, profusely sweating. Treatment, it all depends on the underlying cause. But in general, just like everything else, you're gonna think of kind of like your ABCs of first response. You're gonna check airway, breathing, pulse, etc. Specifically, cardiogenic shock is inadequate output of blood by the heart, typically associated with MI or certain arrhythmias and valve failure. Okay, so moving on to vascular conditions. These are conditions related to issues with blood vessel walls. Remember, our blood vessels have 3 different layers. The intima, which is the smooth, thin endothelium on the inside. The tunica media, which is the smooth muscle and the elastic type tissue in the middle, and our tunica externa, which is our outermost layer of primarily connective tissues. Remember, the tunica media is really what separates a artery from a vein, as smooth muscle doesn't really exist on veins at all, and arteries are specifically arterioles, are the primary way in which our body regulates blood pressure. So an emboli, this is a clot of aggregated material that gets dislodged. So basically, it's a thrombus, which is a clot that's not moving, that starts moving. Signs and symptoms, you get sudden severe pain related to an occlusion. Patient often goes pale, numb, cold. You might also see, your typical MI type symptoms, and you can also have your typical stroke symptoms. Most common cause is a venous thrombosis, a deep vein thrombosis, typically from the lower extremity. Patient, before this happens, they might actually have reported calf pain or pain in the leg, right? So if they're having that, it is worth following up. There might be extreme swelling in the lower extremity in that area. It might be really red. You can see, ideally, you catch it in that stage, because they can do things like provide medications like clot busters, or they can go in with a catheter and pull out the thrombus. So, arteriosclerosis, we've talked about this already. This is hardening of the arteries, not to be confused with atherosclerosis, as atherosclerosis is while related, is a different specific disease. There's also Monkeyberg's arteriosclerosis and arteriosclerosis itself. Monkeyberg's arteriosclerosis is sometimes termed medial calcific sclerosis. That involves the tunica media only. So there's destruction of your muscle and elastic fibers that are replaced by calcium deposits. You can actually commonly see this in people that have it. You see it in their hands and feet on x-rays. It's rather interesting looking. So atherosclerosis. We get thickening and hardening of the arteries, but we also get plaques full of cholesterol and other lipids forming in the arterial tunica intima. So again, this is all the symptoms we talked about of things like angina pectoris and reduced blood flow. Risk factors. Big lifestyle condition, but there is a role in heredity, diet, smoking, environment, etc. So this is just a quick overview of what this really does. It's a pretty gnarly process, and just to highlight how resilient the human body can be. People can have blockages of arteries that are 80-85% and not even know it. Right? The body is incredibly resilient, but it's incredibly dangerous to have a blockage that's that large. The diagnosis, again, you look at the person's entire health. You look at their blood labs to include their complete metabolic panel. Look at stuff like cholesterol, triglycerides. You even want to look at glucose levels. So what are things we do for treatment? Lifestyle modifications, including exercise, dietary changes. You stop smoking. If there's hypertension, you treat the hypertension. If there's hyperlipidemia, you use your anti-hyperlipidemic drugs, primarily your HMG-CoA reductase inhibitors that you all see on the screen. Those are your statin class drugs, and luckily, makes it easy to remember, they all end in statin. Next, an aneurysm. An aneurysm is a weakening of an arterial wall, and you get local dilation of it. Atherosclerosis can cause an aneurysm. The symptoms, typically in an abdominal aneurysm, you're going to have abdominal and or back pain. There can be a pulsating mass that is visible externally, and you might also see symptoms of signs of hemorrhagic shock, especially if the aneurysm has ruptured. Diagnosis: you hear a bruit in an area where there should not be a bruit. Basically, a bruit is the sound on auscultation is the sound of rushing blood. There are areas of the body where you should not hear anything when auscultating over a blood vessel. You can sometimes see it on radiographic studies, particularly on X-ray, if there is calcification of the aneurysm walls. Ultrasound and CT, though, specifically ultrasound, is pretty much the primary way to examine this, though, and you do want them measured. There is a measuring scale. Typically, if it's over 7.5 millimeters, you're sending the person to the emergency room. They're meeting with a vascular surgeon. If it's between 5.5 and that 7.5 range, you're setting the person up with a vascular consult. And then if it's 3.5 or smaller, you can kind of ignore it, because some people would even say that a 3.5 millimeter dilatation isn't even that. Some people wouldn't even call it an aneurysm. The treatment depends. Sometimes they do surgical repairs. Sometimes they put stents in. It just all depends on the specific patient, what vessel it's in, etc. Next, thrombophlebitis. This is inflammation of your deep veins. It affects your tunica intima and it increases clot formation. So really what you're going to get, just like we talked about before with your DVTs, your deep vein thrombosis, you get pain, swelling, heaviness of the limb, a warmth, and you can even have signs of inflammation like chills and fever. Treatment, you need immediate intervention. So you immobilize to prevent the thrombus from spreading or dislodging, and you use heparin, which is a blood thinner, an anticoagulant, essentially. It shuts down the blood clotting cascade. Antibiotics are also given to prevent infection. The varicose veins, this is something people have commonly heard of. Remember, our veins have one-way valves, so as blood in the legs returns to the heart, it is pushed by both our passive venous blood pressure, as you know, the blood pumps from artery, capillary to vein. You get a little bit of pressure that way, but primarily from our lower extremity, you get pressure from your calves. And people that have this condition, you typically actually are rather inactive. But there can also be genetic predispositions, etc. So with this, the valves become incompetent and can even collapse, and that leads to an excessive amount of blood pooling in certain areas of the veins. The symptoms, you get a feeling of fatigue in the veins, a dull ache, leg cramps, swelling ankles. The veins can also become hard to the touch, and this can predispose you to clotting events. Predisposing factors include defective and absent valves, prolonged standing or sitting, particularly individuals that are inactive. Diagnosis, a lot of times this is easy to see. Pregnancy is also another predisposing factor. Treatment. So you elevate the feet higher than the heart. You engage in exercises like basic ankle pumps or soleus push-ups, warm water submersion, support stockings, and individuals that stand for long periods of time are essentially given a prescription to ensure they are moving their legs to kind of get the effect of the lower extremity muscular pump. There's also other treatments like venous ligation or injection of sclerosing solutions, but those are hit or miss on if they're used. The Raynaud's disease, this is a rather interesting condition. It can be both primary or secondary. It's a vasospastic condition of our fingers, hands, or feet. You get pain, numbness, sometimes, and it says sometimes discoloration, but in reality, there is discoloration. They always talk about how your digits basically go white, blue, then red. Okay, so you get blanching due to the fact that there's a vasospastic event. There's not really a lot of blood. It gets blue as venous blood starts to pool in the hand, and then red and purple as circulation is normally restored. In this condition, it is actually incredibly dangerous and can cause circulatory compromise and tissue necrosis, which may result in the need to amputate fingers, toes, or even a whole hand or lower part of an arm. Typically affects women between puberty and the age of 40. And again, this is likely related, one of those conditions is likely related to estrogen and the fact that estrogen is a powerful vasoconstrictor, which is also why it's theorized that women are more prone to migraines. Treatment of Raynaud's. So apply warmth to the area. You make sure the area stays warm. That's also a preventative measure. So good quality gloves, wearing good jackets when it's cold outside, and Raynaud's can also be related to heat. So be careful with warmth as well. So blood dyscrasiase. I can never say that word, but basically we're talking about conditions here where there is disruption in the cellular content of blood. So this is starting with your hemocytoblast. This is the embryology pathways of every type of blood cell that we have here. So the first one to talk about anemia, condition where we have a reduced ability of red blood cells to carry oxygen. Normally is associated with reduced red blood cells, reduced hemoglobin concentration, or just another type. It could also be another type of dysfunction of the red blood cell. There's lots of different things that can cause anemia. Lots and lots and lots of different things. Most common thing, though, is iron deficiency. Symptoms, wide-ranging, but the first thing you generally think about is fatigue, headache, and trouble breathing. In more severe cases, you'll start to see like pallor. The person becomes pale. They might have numbness and tingling, particularly if it's related to vitamin B12 deficiency. So there's lots of different things. So classifications, again, different types. You got your aplastic anemias, folic acid deficiency, iron deficiency, etc. Ultimately, the primary way you differentiate them out is literally just looking at what their underlying cause is. Iron deficiency anemia, you'll find things like your ferritin content will be abnormal. Your transferrin content in the blood is also abnormal. Sickle cell anemia, you just look at the shape of your red blood cell. In this case, it's shaped like a sickle. Anemia also can include both macro and microcytic forms, meaning the cell is small or the cell is big. Treatment, again, treat the underlying cause, go from there. Polycythemia. So this is a abnormal increase in red blood cell count and or hematocrit. Basically, too many red blood cells. So you can see this when there is dehydration, plasma loss, fluid imbalances, and burns. Symptoms, lots of different symptoms here. Not necessarily direct, but interesting things that you might see are splenomegaly, clubbing of the fingers, and cyanosis are also possible. Diagnosing this, you get an abnormal increase in your RBC, hemoglobin, and hematocrit. All of those things will be elevated. You might also see your white blood cells and thrombocyte counts are elevated, and on physical exam, you'll have splenomegaly. Leukemia. So, leukemia is a white blood cell cancer. You get uncontrolled proliferation of a lymphoid or myeloid cell, basically your lymphoid or leukocytic varieties. So, couple of the main classifications of this. Acute lymphocytic leukemia. This is the most common childhood leukemia, but it still does occur in adults up to 20% of the time. You get a overproduction of your lymphoid cells, which are your essentially your B and T cells. It will be subclassed based on whether it's B or T cell ALL. Symptoms, big things to look out for with cancer are bone pain that is intractable, meaning no matter what you do, it doesn't go away. Sudden weight loss that's unintended. Fatigue, fever, and night sweats. All of those things, as well as your increased bruising and bleeding for all of these, right? Everything that is listed here is major red flags, especially when they're all present. Diagnosis, you do a blood smear. You check the blood type. You check the blood, check the types of cells, their presence, and then you may need to do a biopsy. Treatment, it's very common for this to affect the central nervous system. So you do use a intrathecally administered chemotherapy, even if you don't have evidence of this in the central nervous system. It can be rather dangerous. Next, chronic lymphocytic leukemia. This is typically diagnosed in individuals that are about 70 years old and male. There is a genetic predisposition to it, but it is a slowly progressing disease. Interestingly, in this case, the lymphocytes that are found look normal, but they're actually poorly functioning. And this is the most common leukemia in an adult. So again, notice here, you get a lot of the same exact symptoms. Big difference with this is you'll rely a lot more on swelling of your lymph nodes to determine. Typically, a malignant condition is going to involve hard, immovable lymph nodes that are painless. If you have an infection causing increased sizes of your lymph nodes, they're going to swell up quickly, they're going to be movable, and they're going to be painful. If they're the exact opposite of that, so they're painless, immovable, and slowly enlarge, that's typically a problem. Diagnosis, often incidental. It's slow growing, right? So it typically it's just your regular routine blood work, which is why routine blood work can be so important for people. So there are different stages of this. Depending on where you catch the patient in the stages, depends on how long they tend to live afterwards. Treatment, chemotherapy, radiation therapy, monoclonal antibody therapy against B lymphocytes, all important. Next, acute myelogenous leukemia. So this is myeloid involvement, meaning you're going to see the leukocytes, the true white blood cells, your neutrophils, etc., involved. This is 80% of all acute adult leukemias. So you get symptoms of anemia, very easy bleeding, increased infection rates, bleeding randomly. In fact, epistaxis that occurs out of nowhere, epistaxis and gingival bleeding are major red flags if there's no other conditions going on. The hour rod presentation in laboratory blood smears is a very, very, very important finding. That's basically a abnormal lysosomal granule measurement that's visible within a leukemia cell. At least half of patients with AML have this. So treatment for it, very standard. CML, chronic myelogenous leukemia. This is typically that leukemia that's for people, between the age of 20 and 40. But generally about 40 is what you see there. Interestingly, CML is related to an abnormal chromosome 22, which is termed the Philadelphia chromosome. So in this, you get your very standard cancer type symptoms. You see all of these things at once, and you definitely know you need lab work in that patient. So treatment, again, only about 25% of the patients can get a hematopoietic stem cell transplant, and that's the only way to truly cure it. Remember our transfusion incompatibility reactions. When we talk about transfusing blood to somebody, our body has antigens, and if we have different blood markers, we end up getting antibodies to those blood markers, and it causes an agglutination response. So in our examples here on the top, you see a donor with type A blood with A agglutinogens. There's no binding, there's no reaction here. B, what you get is a donor with type B blood with a type A antibody for agglutinins, and you see agglutination. What happens with that is basically the formation of what's termed an immune complex, and you get these massive amounts of clotting that occurs. You get circulatory collapse, and it's basically shock at that point. Treatment. So at first indication, you stop the blood transfusion and you start administering antihistamines and other types of anaphylaxis type of treatments. Another important thing to talk about is classic hemophilia. Hemophilia is basically a bleeding disorder resulting from deficiency of clotting factors. The clotting cascade that we're going to see on the next page is rather complex, and there's things that affect it in different places. But basically what happens is, in this case, you have a defect with your factor 8. Here, there's a defect in factor 8. Symptoms, you get prolonged bleeding, easy bruising, hematomas, excessive nosebleeds. Typically is diagnosed in childhood, and there is a very high Prothrombin time. Yeah. You will provide concentrated factor 8 to help stop the bleeding. Ultimately, it cannot be cured, but treatment does help prevent long-term permanent crippling disability. Another thing to think about is disseminated intravascular coagulation, or DIC. This is where there's sudden hemorrhage and thrombosis all at the same time. This is secondary to another disease or traumatic event. Basically, what you get is a hemorrhage, but then there's also an inappropriate response of thrombin causing massive platelet aggregation and more clot formation. So come back here. Thrombin is this guy right here. Thrombin. Thrombin is where we really start to get the signaling to create the fibrous mesh and the formation of a clot. So risk factors: hypotension, hypoxemia, acidosis, and stasis of capillaries. Symptoms: so you're going to get oozing of blood from any puncture sites, mucous membranes, bleeding in the form of various types of bruising like petechia, purpura, hematomas around wounds, hematuria, bloody stools, etc. Patients also typically have headaches, what's called like air hunger, like they're gasping for air. They feel like they need more air, but their blood oxygen is not as bad as you would think. It typically follows things like obstetric complications, so issues related to childbirth, septicemia, trauma, large burns, and hypothermia. Treatment: so you administer IV heparin, use platelet replacers, and plasma clotting factors. It is life-threatening. It's very often fatal. It needs incredibly quick treatment. Okay, but again, it's secondary, so not only do you need to provide these therapies, but you have to address the underlying cause. And you'll also be sure to continue to monitor platelet count, fibrinogen levels, and prothrombin times. So that is everything for our cardiovascular discussion.